Everyone, thank you for coming. Welcome to NADO's 38th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments in the chat and questions in the Q&A. We hope you will take advantage of this opportunity to engage with our speakers and attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in our daily drawings. Now, let me turn the stage over to Norm Thurston, NADO's Executive Director. Norm, the stage is yours.
Well, thank you, Erica. It's wonderful to be here with everyone. We're excited to have you for our annual conference, Building a Bridge Between Data and Policy, especially this session, which is our Igniter session. We've done something different this year. This year, we had several student submissions, which we don't normally get, but there were a couple of them that were high quality, and we wanted to make sure that you had an opportunity to see what the next generation is thinking about in terms of health data. So this student session will highlight the very best student submissions that we were able to find. Today's moderator is going to be Victoria Razin from Georgia Tech Research Institute. Victoria, welcome. It's good to have you with me. And I'm going to go ahead and have you take it from here.
All right. Thank you so much, Norm. And thank you, everybody, for being here today. I'm really excited to introduce our three panelists today. So we have three students who have done some impressive research related to health data. To start us off, I'm going to introduce Melina Malkani from the Bullis School and Dillon Malkani from the University of Pennsylvania. Now we're going to hear a presentation from Melina.
Good afternoon. My name is Melina Malkani, and I'm currently a high school student at the Bullis School. Specifically, I am from Bethesda, Maryland. I've created a presentation on a topic that is increasingly important in our digital age, the design of a health dashboard. In our world of technology, AI, the internet, and data-driven healthcare, it is imperative for the public to be able to understand healthcare data easily in order for them to take charge of their own well-being. One of the easiest ways to receive health data is by reading dashboards. However, if the dashboards are hard to read, then they are of no use to the public. That is why I have researched the best practices for the design of health dashboards. I believe my research results will make an impactful change due to health dashboards if implemented. I have spent numerous hours conducting research on this topic, and I'm very passionate about improving social good. On the screen, I have linked my email and contact information as a resource. Please feel free to take a picture or write down my contact for more information about the best practices for the design of health dashboards. The start of my research began during the height of the COVID-19 pandemic due to my brother's and I's curiosity about the impact of COVID in our community. We decided to check our county's COVID dashboard for data, which included hospitalization numbers, deaths, and cases. However, the dashboard was very hard to read, even for educated individuals. I thought, how would elderly people be able to make informed health decisions if they can't understand the dashboard? So I decided to research how to make dashboards easier to understand for the public. Therefore, I initially came up with the top 10 best practices for the design of COVID-19 dashboards, but I realized that those practices could work for all types of health dashboards, for example, monkeypox or cancer dashboards. Currently, the research topics that my team and I have focused on have been health informatics, medical informatics, and data visualization. These keywords have allowed us to focus on big data informatics to enhance health dashboards. As a certified Tableau creator, it has been very insightful to be able to identify the use of diverse chart types of displayed data. For example, bar graphs, pie charts, line charts, and others. In the future, I'm looking forward to expanding my research into improving non-medical dashboards, such as financial dashboards, and scientific dashboards, such as biochemical dashboards. Dashboards are the future of interpreting data and provide a visual representation of complex data sets. I am seeking a co-author on this research to create a well-designed dashboard to produce better informed health decisions. A well-designed dashboard can produce better decisions made by the public, academics, managers, organizations, etc. The methods. My team and I have created a 550-person survey including many different demographics, asking questions about the necessity of each of the best practices for health dashboards that we've researched. Those are easy navigation, high usability, use of adjustable thresholds, use of diverse chart types, compliance for Americans with Disability Act, use of charts with tabulated data, incorporated user feedback, simplicity of design, adding clear descriptions for charts, and comparison with entities. The conclusion of the survey aligned with our best practices because the percentage of agreement with all the best practices was over 75%. Additionally, we looked at over 110 different COVID dashboards and collaborated with the Montgomery County dashboard team. After we collaborated, the Montgomery County dashboard team have implemented the practices that we suggested into their own dashboard to improve their design. During our survey, we made sure that we implemented many different demographics. For example, we sent the survey to 7 different states and 5 different age ranges. This ensured that we would get varying perspectives towards our data. Our results. Due to the conclusion of our methods, we realized that the public agreed with all of our best practices with a high agreement rate. So we decided our top 10 best practices would consist of easy navigation, high usability, use of adjustable thresholds, use of diverse chart types, compliance for Americans with Disabilities Act, use of charts with tabulated data, incorporated user feedback, simplicity of design, adding clear descriptions for charts, and comparison with entities. Here an example of a great design of a dashboard. As seen, it contains 2 different chart types that allows users to understand data in 2 different ways. Additionally, this dashboard contains a clear title that allows users to know exactly what they are looking at. Lastly, the only improvement for this design would be to pick colors that would be ADA compliant. Around 300 million people around the world are colorblind, and it is important to have dashboards that are inclusive to all users. Next, an example of a poorly designed dashboard. Just on one page, there is too much information displayed. Firstly, the colors are not ADA compliant because they are using lighter colors instead of bold colors to indicate change on the graph. Second, there is not an option to change thresholds of the graph. It only contains data ranges of a 30-day time period. Third, the titles on the graph are not descriptive enough for the user. However, displayed are multiple different chart types, which can be useful to the user. Lastly, references. I will display my contact information for any additional questions that are concerning. Thank you, and here's my contact information.
Victoria? Sound check.
Apologize for that. Thank you. Okay. Thank you so much, Melina, for that presentation. I want to invite everybody in the audience to please leave comments in the chat area. And if you have any questions for the presenters, please use the Q&A area for that. And then I'm going to start us off with a couple of questions. All right. So the first is just to state the obvious and the incredible, which is, Melina, you're in high school. Dillon, I think, are you an undergrad or a grad student?
Yeah, I'm an undergrad freshman.
Okay, so wow. I think it's just incredible that at your phase in your careers now, you're already doing health data research, you're already publishing, you're presenting on a national level. So just want to say kudos, first of all.
Thank you.
Thank you.
So for the first question, I'm actually a fellow Montgomery County resident, and I was struck by the direct impact that your research has had on your counties and on our county's dashboards. And I was wondering if you could share with us some of the changes that the county made to their COVID dashboards based on your feedback.
Yeah, I can take this question. So I think the first thing we wanted to do after we began our research on COVID-19 dashboards was we wanted to reach out to the Montgomery County Dashboard Task Force. So this was during like the height of COVID, and we were able to get a meeting with them, and we presented them I think we presented them 15, at the time we had 15 best practices, which we later cut down. But we presented them those practices, and their favorite one that they wanted to implement was the comparison with other entities, and the entity being other counties. So I think the first thing they did after they met with us was they added a comparison with the rest of the counties in Maryland to their dashboard to improve it.
Wow. Now I'm curious about, you said that you originally had a set of 15 best practices that you narrowed down to 10. Can you tell me about the process for narrowing down those best practices?
Sure.
There you go.
So we had we wanted to implement a survey, and so we had different people from different states, around 7 different states, and 5 different age ranges take the survey, and we asked them which of the 15 would be the most useful, and we asked them the questions of yes, no, or to some extent, and we used the top 10 practices that had the most percentage of agreement in our research.
Thank you. I've got a couple of questions from the audience. So Norm asked if you had to choose just one best practice. If you had to choose just one best practice that everyone would implement, which would be most important to you?
You want to go, Melina, or should I?
Sure, I can go. I think the practice that I think would be most important would be simplicity of design. So simplicity of design, if you can't really read the dashboard, it wouldn't be of use to people because it would be too complicated for people to understand what data is going on. And I think it's really important for the public who are reading the dashboard to be able to understand what data is being given and to what's being compared to. So I think simplicity of design is one of the most important ones.
Yeah, I agree. I think the most important thing, or the thing for a dashboard to display, like before, I think what the pandemic brought to us was the public getting more involved with reading data dashboards and getting more interested in healthcare dashboards. So with the growing interest of healthcare analytics, dashboards, I feel need to be standardized so that like everyone from like my grandmother to like my little sister can be able to like read and interpret what a dashboard is saying. So I think simplicity is definitely the most important, which is what our survey also agreed with. That was the highest rated.
Thank you. I'm not sure if you guys can see it, but you are getting so many kudos popping up in the bottom left corner of my screen. So I just want you to know how much everybody's appreciating the research that you're doing. And I also want to go on to the next question from Norm, which is, what are your plans for expanding research?
So right now our plans to expand research are to go back to the top 15 best practices, and we included more of the best practices, such as implementing AI into dashboards. We found that over doing research that if you implemented AI to show the potential change and trends of the graph, that more people will be likely to will be able to predict what will happen in the future, and will be a tool used for the public to be able to use this data for their own well-being and their own self. So we're going to implement 5 other best practices and have another survey go out and see if AI would be really beneficial to the public when they're reading and interpreting data.
All right, well done. Thank you both so much. Next, I'm going to introduce our next panelist. So I would like to introduce Jacob Zelko. Jacob is a master's student in applied mathematics at Northeastern University and is also the Chief of Global Health Informatics at OneFact. Now I'd like to turn it over to Jacob for the presentation.
Thank you so much for coming to my talk, Health Economics, Analytics, and You, an early exploration of patient economics using real-world data. My name is Jacob Zelko. A little bit about me before we dive into everything is that I'm currently an applied mathematics master's student at Northeastern University, and I'm also a trainee affiliate of the Ryu Institute, which is also part of Northeastern University. Additionally, I work at the nonprofit organization, the OneFact Foundation, as the Chief of Global Health Informatics. And beyond that, I tend to do a lot of volunteering, both in the programming space, the summer mentorship and fellowship programs through Google, and I'm also an educational outreach streamer on platforms like YouTube and Twitch. So coming to you live from here on this recording is just like home for me. So to give a quick overview of what we're up to over at the OneFact Foundation, we have a couple different work streams such as ChildFX, which is a AI-based radiology tool for pediatric radiology, Data Thinking, which is courseware and coursework for learning how to do open source analytics within the space of health informatics, and Clinical BERT, which is a AI-powered discovery engine for healthcare researchers. But in particular today, what I'm talking about is the project Payless Health, and this is a US-based platform that enables users to search across hospital pricing, negotiate rates, health outcomes for a variety of different conditions and care site locations. Our approach for this project has mostly been to train teams and work with public and private individuals such as patients or interest groups, as well as employers and maybe teams at different sorts of companies trying to make sense of how to analyze the plethora of health information that is available. In fact, we've taken some of this analysis that we've done and run ad campaigns throughout New York City. Seen in this figure here is a little infographic about the cost of C-sections varying by just going to 2 different hospitals in New York City. You can see a price difference as much as nearly $50,000. So to emphasize or talk about how these analytics work and how we can come up with these numbers, let me go through a couple demonstrations where we first look at hospital price sheets for various hospitals across the United States. So for us at the OneFact Foundation, we coalesced publicly made available hospital price sheets for about 4,000 different hospitals, and we have them hosted on the Payless Health website. Now I'll show that in just a moment. And all of these different sheets are tagged with the CMS certification number and hopefully is available as an easily navigable web interface. So to show what that looks like, let me go ahead and show this live. So here is the Payless Health website repository. I'm happy to share a link about this after the talk. But if we go to the directory Hospital Price Transparency, seen here are all the different charge master sheets for different hospitals across the United States. As you can see, they exist in a variety of different formats, but all of them are prefixed by the 6-digit CCN number. So if you have hospitals that you want to look up, you can quickly go through this and look up one particular hospital that you might be interested in, such as this. Now coming back to the presentation, something that I want to talk about is building off of these hospital price sheets is the fact that taking this patient or not patient, but rather this insurance information is non-trivial to crosswalk it back to patient level data. As you saw, there was a variety of different formats available for this information, such as CSVs, spreadsheets, PDFs, Word docs, anything that you can think of. It's probably within this coalesced collection of charge master sheets that we have access to. But for this talk, for this demonstration, I am going to show some results from a proof of concept analysis that we've been doing using what is known as the MIMIC3 database. This is a publicly available, or not publicly available, but rather patient-level database that operates on a public standard called the OMOP Common Data Model. We're not going to get into the details about what the OMOP CDM in this case is, but just know that's a patient-level way of understanding and working with patient medical records as well as patient medical claims data. And in particular, this data set also has DRG code information, DRGs meaning drug-related groups. And for this particular demonstration, I'm going to show a very rudimentary crosswalk data analysis that I've been pursuing working with MS DRGs, and in this case, MS standing for Medicare Services DRGs. So for example, with this data set, which does have about 50,000 patients in it, and a subset of those who do pursue or do receive care under the MS DRG envelope, we can look at these patients who receive care in these DRG groups and see what might be the most frequently occurring conditions. So seen here, we can see that number one is coronary arterial sclerosis, and then essential hypertension, and so on and so forth. And similarly, you can do something similar with procedures, looking at the top 5 most frequently occurring procedures with patients receiving care underneath DRG envelopes. And then finally, we can also look at specifically what these DRGs might be, who's receiving care within these DRG groups, and how that looks. And in particular, if we want to actually look up what these DRGs actually are, we can by going over to the charge master for the MIMIC-3 dataset. The MIMIC-3 dataset is actually based out of Beth Israel Deaconess Hospital in Boston, Massachusetts. So we just can look that up from the repository that we have together, and we can look at DRG codes such as 101 seizures without MCC, and then we can also go through and using the charge master sheet actually see negotiated rates, gross charges, and how payer fees break down across all the different payers that are made publicly available by Beth Israel Deaconess Hospital in their charge master. And shown here at the very end of this spreadsheet is we can also calculate things such as row mean or row standard deviation to see the variation of rates across different payers. Now coming back to the presentation, the question might be, how can we actively make this material actionable to both health researchers as well as patients and other sorts of consumers interested in this information? Well, using data sets that have the ability to crosswalk from the patient level data all the way up to the charge master billing sheets, we can actually create some really interesting and meaningful dashboards that help elucidate more about the health economic continuum of patient care. So seen here is one example looking at Houston Methodist Hospital using the charge master billing sheet for that hospital. If we want to, we can go ahead and look at something like coronary bypass with cardiac catheterization, and we can see not only the spread of the different negotiated payer or negotiated rates for each payer, but we can also see how that compares to all the rest of the payers shown here. And moving on to perhaps more exotic or grandiose thinking of how we can take publicly available information across the United States and make that additionally actionable in a health economics context. Seen here, we can actually use the CMS Hospital General Information Dataset, and we can actually look at all the different hospitals across the United States, zoom in on particular hospitals, and, for example, create a map across the U.S. looking at different quality metrics as well as safety measures across the U.S. And finally, as kind of a big picture, very inspirational way of thinking, we can also think about using this publicly available data to look at even making maps such as these that show wait times across the Manhattan Island, and just seeing how we can take advantage of these different sorts of information and make them readily available and accessible to consumers. So as we move on to the conclusion of this talk, our tentative future plans for this work is to look at a couple different papers, such as healthcare costs and quality metrics analysis from this public available information, and look at urban versus rural essential hypertension using some of this crosswalking that I'm talking about. And if you have any questions, please let us know. Please don't hesitate to reach out to me. And I thank you all so much for your time being here, and I'm happy to take any questions about how we can turn this information into actionable patient outcomes as well as support our patients. Thank you.
All right, Jacob, thank you so much for that presentation. Once again, I want to invite everyone in the audience to feel free to put comments in the chat and put questions in the Q&A section. I'm going to start off with a couple of questions for Jacob. So the first one is, what challenges are there with using hospital charge master sheets in research?
Yeah, so it's a really complex, kind of broad question. I didn't really touch much in the talk itself, but speaking to especially like researchers who want to go in and use this publicly available information, what I've oftentimes run into is I mentioned that a lot of these different charge master sheets come in different file formats. So it makes kind of, doing analysis across different hospital sites, collectively a little challenging, because sometimes as an analyst or as a researcher, you actually will have to look up your hospitals and then do your own pre-processing of these charge master sheets yourself. So there's not really a one-size-fit-all solution for this just yet.
Thank you, Jacob. I also want to note that you are getting a number of positive comments in our direct chat. And now on to our next question. How could this information be made more accessible to consumers?
Yeah, it's a great question, and I love the previous talk because it talks so much about dashboards, and here I was also showing like here's some dashboards that we've been collectively developing and experimenting with, and I think that idea of taking this information that's available, parsing through it and analyzing through it, and making it deliverable or viewable in readily accessible ways to anyone at various levels of familiarity with the space. I think that's going to be the key. So actually, the previous talk I thought was fantastic, and kind of teeing up this particular discussion, and leads into that question that you were just asking, like what's the best? And I think those best practices, how we can develop winsome ways of showing information. I think that's going to be the key.
Absolutely. And I'm glad that you mentioned the previous talk as well, because I'm very much looking forward to the part of this discussion when we'll bring you all together and we'll get to discuss dashboards and best practices together.
I love it.
All right. Another question is, if you could make one suggestion to the NATO community about how to conduct analytics research, what would it be?
Oh man, that is a fun question. Yeah, so I absolutely love the NATO community, and I love what's going on here across all the different APCDs, the different groups working with this data. And I think for me personally, if I was to make one recommendation, is to still continue thinking around these lines of how can we both standardize and share experiences with one another as a researcher community. Especially I mentioned the not one size fit all solution doesn't exist yet for these charge master sheets, but how awesome would it be if we can continue to maybe use standards? I mentioned like the OMOP CDM in my discussion around health analytics for patient level data, but if things can start emerging like that between the APCD communities and building us all contributing together, building tools that we can share with one another, I think that's going to go a long ways to galvanizing how we can make use of this information for everyone in the NATO community, not just one site, but all the sites. So that'd be my thought for the community.
Thank you so much, Jacob. Do we have any questions from the audience for Jacob? Give it 1 minute. Okay, great. We have a question from Norm. How have efforts at data standardization impacted your work?
Yeah, And actually, I'd say very quickly, it's significantly impacted my work, but in a very positive way. In that, having these standards I mentioned earlier, the standardization really does lead to, eventually like reproducible sort of work, reproducible sort of pipelines, and especially coming from both, wearing my researcher and analyst hat, I think it makes it as researchers very clear and articulable about how to actually go about using this information in a standardized way, and then being able to explain it, in common language that we can all agree upon and understand. So I think it's impactful in a very positive way. I guess that's how I'd answer the question.
Okay, thank you, Jacob. Now we're going to bring our other panelists in, and we're going to have a discussion together for about 10 minutes. All right, hello, everybody.
Hi.
Hi. So you both touched on dashboards with your presentations, and I wanted to ask you actually something that you learned from the others' presentation, perhaps, or something that you noticed. So Melina and Dillon, is there a dashboard representation that you noticed from Jacob's presentation? And then I'll have a second question for Jacob.
Yeah, I mean, personally, the one that stood out to me was the wait time in Manhattan graph. That I think it's really important in this like new digital age, I guess, to implement these like interactive type graphs that that are like easy to visualize, and like the 3D graph was that was pretty cool to see, in my opinion.
I agree with the 3D graph. I've never seen something like that, and it was really interesting to see it.
I agree also. I was definitely struck by that 3D graph. I think that it's a great example of health data visualization. Jacob, based on what you've learned from Melina and Dillon's presentation, are there any best practices that you would want to integrate into your next data visualization?
Yeah, no, I absolutely love the presentation, and thanks for the kind words on that, the 3D visualization. That was in collaboration, with my colleague, Dr. Jan Altazar Lee, and it's really exciting to see, pushing the boundaries into what we can do to make it as accessible as possible for folks. And I think for me personally, something that struck me was kind of just something kind of quick, but it triggered something in my mind when you were talking about, you're showing a dashboard that you thought wasn't maybe the best or didn't follow these best practices, and talking about, for example, the colors of the dashboard, saying like that's not, it goes against ADA recommendations, and I thought that's a great point. And I think, when getting started with especially accessibility when it comes to dashboards, how we can introduce these best practices might not even need to necessarily be, these huge undertakings. And for me, I was thinking like, oh, what if, you can build some sort of tool? That's where my mind was going. What if you could build some sort of tool that, takes a screenshot of different dashboards, look at the color composition of like dashboards and see like, based on, the colors that are present, are they harmful to folks with, various types of, I'm thinking like vision impairments. And then, going from there, you could probably build, some more interesting sort of tools that aren't really like anything quite sophisticated, but more just like getting that really quick, sort of insight into, does this dashboard from a high level look accessible? And if not, where can we fix it?
Yeah, you got it.
That was a great idea. I think we should really look into that.
Awesome.
All right, we have a question from the audience. So this is a question from Betty Harney. Can you share any data cleaning that you had to do before analyzing and presenting visualizations? And I think this is a question for Jacob.
Yeah, so to speak kind of briefly to that, I didn't get into it so much in the presentation just because that, that's the part that, in these presentations we kind of sweep under the rug, if you will, sometimes, just because a majority of the work really does boil down to how can we prepare and, clean up this data. So like I mentioned, we're using a database called the NMIC3 database. This had about 50,000 patients in it. And then, there was a lot of manual investigation and mapping that had to be done to, map this patient level data to the, charge master sheets. So going from patient level all the way up to, this publicly available charge master information. That did take some time. But once, I walked through that, process, it became very clear to me, like, okay, we can probably repeat some of these processes in the future much more quickly. In particular, just one very quick thing that I'll end off on is I'm very enthusiastic because my colleagues at the One Fact Foundation, we've been exploring the use of large language models to perhaps use them to munch through some of these charge master billing sheets to pull out relevant pieces of information. And rather than having to rely on manual processes that would take hours upon hours of manpower to parse these billing sheets, we were thinking about how could we implement LLMs into this pipeline. And for what I'm talking about like tools like ChatGPT or these other sorts of AI tools to parse through and understand these really confusing text files that can be generated.
Something that struck me about all of your presentations actually is the direct impact that you're having on counties and cities in America. So Jacob, in your presentation, you showed a sign in New York City that's got your health data up on there. And Melina and Dillon, you shared the impact that you had on the Montgomery County COVID dashboards. So I just want to ask you, what advice do you have for other students who are interested in having an impact like that on their communities? And I'll start by asking Melina.
So some advice that I would give other students would be to think of a problem and try to find a solution or many solutions to it and go to the place where you think it would have the most impact. So for example, ours was the Montgomery County dashboards. And even so, at first when we sent an email to them, they didn't respond. So we had to send like maybe 2 or 3 emails to them to just get a response from them. So I would say
it was like 6.
Yeah. So maybe I would say just keep trying and eventually something will happen out of it if you're trying to do something for the social good.
Dillon, what do you have to add?
Yeah, I think persistence is definitely key to like doing social good, because so many people are trying to do the right thing and they're obviously not going to want to hear from a little high school student who's trying to give them ideas at first. But if you really show like who you're trying to reach out to, who you're trying to make an impact to, like if you show them that you're trying to make a difference and that you've done good research and you know what you're talking about, they'll give you a chance. And when they do, you gotta make it worth it. That's my advice.
Jacob.
Yeah, it's a really interesting space. And I guess for any student, whether we're talking elementary school all the way up to, graduate and beyond, student of life, if you will, all the continuum, I would say just go for it, honestly, just because as you go through, these processes, you're inevitably going to, not know everything going into that. And that's perfectly fine. But, I guess, the first step to becoming, good at something is just trying it out and seeing, what you can learn from that experience. And I'd also suggest, just wherever possible, is to find community where you can really, connect with and receive either mentorship or support from people across, your interest range. And I would, keep looking for those people who will push you, who will encourage you to keep going forward. And that's the wonderful thing kind of about like the internet age is that, you can find those people, whether it be, across social media, different, messaging platforms, they are there. And so I would just suggest like keep going. Like, just get started. That's how I got started with programming. I didn't know programming. I thought, let's do it. And so I just started. So that's my recommendation.
All right, thank you all so much. We do have one more question, but we are out of time for now. So what I'm going to do is actually just copy down that question and I will email it to you, Jacob. And then we will need to find a way to get in touch with our audience member, Ertug Surly. Thank you all so much once again. I was really impressed with your presentations, and thanks for kicking us off well with our NATO talks.
Thank you.
Yeah, thank you.